Welcome to the podcast. I'm Jess, a family nurse practitioner and legal nurse consultant, and this is the space where healthcare, law, and real-life situations intersect. Each episode is designed to break down complex medical and legal topics in a way that's clear, accurate, and grounded in evidence, without fear, misinformation, or sensationalism. Whether you're a healthcare professional, attorney, gig worker, parent, or simply someone who wants better understanding of how medical events and legal responsibility overlap, you're in the right place. Let's get started. Hook. I want to start with a short story. A patient I cared for woke up one morning to a crowded bedside. A resident, a pharmacist, a physical therapist, and their nurse. But everyone seemed to leave with a slightly different plan. The family was told the patient could go home, then later told to expect more tests, and the patient was confused about which medications to take. That confusion led to missed doses and a delayed discharge. If that sounds familiar, you're not alone. Small communication gaps during rounds can turn into delays, medication errors, and real stress for patients and families. Today, I'll pull back the curtain so those moments make more sense, and so you can step in calmly and effectively when it matters most.
Promise and roadmap. By the end of this episode, you'll be able to 1. Name who's on the rounding team and what each person is responsible for. 2. Understand the typical flow of a hospital day and where timing affects decisions. And 3. Use exact scripts and safety checkpoints at the bedside so you leave with clearer information and fewer surprises. Let's separate medical fact from fiction and give you tools to advocate without confrontation.
Section 1. Who's who on rounds. Hospitals are team sports, and each person has a specific job. Your nurse is at the center of day-to-day care. They administer meds, monitor vitals, and are the most constant presence. The attending physician is the team lead, ultimately responsible for the plan. Residents and medical students are trainees who present the case and often do initial assessments. Advanced practice clinicians, nurse practitioners, and physician assistants may manage day-to-day orders and patient education. Pharmacists check medications for interactions and dosing, often recommending changes. Therapists, physical, occupational, speech, assess function and discharge needs. Case managers and social workers coordinate home care, durable medical equipment, and insurance-related discharge details. Each role overlaps, and that's by design. Redundancy helps safety, but it also means everyone might ask the same questions at different times. Knowing who does what helps you direct your questions to the right person and avoid mixed messages. A few quick clarifications most patients don't realize. The nurse typically controls medication administration and bedside concerns. The attending signs off on major changes like surgeries or transfers. Pharmacists are the medication safety experts, and case managers can tell you what coverage options exist for home care. If someone uses jargon or says, "That's on the doctor," you can ask who specifically, the attending, the resident, or the hospitalist. Naming the role makes follow-up simpler. Section 2. Typical flow of a hospital day and where information slips. Mornings are when most decisions get made. Early rounds, often before breakfast, are when teams review labs, imaging, and overnight events. That's when plans for tests, procedures, and discharges are set. Daytime is for executing the plan, carrying out tests, therapies, procedures, and patient education. Nights are for stabilization and urgent issues. Timing matters because labs drawn late in the day won't be back by morning, and that can delay discharge by a day. Similarly, if an important update happens after rounds, it needs clear handoff so the next provider knows about it. How information moves, handoffs are critical. Nurses hand off at shift change, physicians hand off between teams, and documentation in the chart is the shared record. Errors happen when someone assumes another person told the patient something, or when chart notes are incomplete. Duplicate questions from different team members are often the result of independent assessments. It's not rudeness, it's safety, but it becomes a problem when messages conflict. Simple red flags you can watch for: if different people give different timelines for discharge, if your medication list changes repeatedly without explanation, or if no one can name the person responsible for a specific decision. These are the moments to ask one focused question and get a single point of clarity. Section 3. Practical scripts and advocacy tools. Here are exact phrases you can use at the bedside. Use a calm tone and label your need as a safety question. That keeps conversations collaborative. Examples. Can you tell me who is the primary decision maker for my care today? When do you expect to have the test results back? Before you leave, can you confirm which medications I should take at home and which to stop? Who will arrange my home care or equipment if I need it? These short, specific scripts reduce ambiguity.
Medication reconciliation checklist, a short bedside routine you can ask for. 1. Ask for a printed medication list. 2. Confirm doses and timing for each drug. 3. Ask which medicines are new, which continue at home, and which stop. 4. Ask about interactions and specific timing around meals or other meds. You can say, please print my medication list and walk through each item with me. Pharmacists often welcome that request. It reduces errors.
Safe discharge verification. 3 things to always check before you leave. 1. A clear medication list with instructions. 2. A written plan for follow-up appointments and who to call for problems. And 3. Any equipment or home care services arranged and their start dates. Use a checklist and ask staff to initial or confirm each item with you. If you hear uncertainty, it's okay to delay discharge until those 3 items are clear. Your safety matters more than speed.
Top 3 takeaways to use on any hospital stay. 1. Ask who is the primary decision maker for the day. 2. Always confirm medication details with a printed list. And 3. Verify the discharge plan, meds, follow-up, and home supports before you leave. If you leave with those 3 things clear, you've done most of what prevents common post-discharge problems.
A few final thoughts. Be kind, but persistent. Hospital teams want safe discharges and good outcomes. Most staff will welcome clear questions. Label concerns as safety checks. It keeps the tone constructive. If something feels off, inconsistent information, missing medication details, or no clear discharge plan, ask to speak with the nurse manager or the case manager. You can also ask for printed instructions and a direct phone number for follow-up. If you found this episode helpful, please subscribe to FAQ by Nurse Jessi for more myth-busting, practical healthcare episodes. Episode notes and sample scripts are available at faqbynursejessiconsulting.com/episodes. Download them, print the medication checklist, and keep them in your hospital bag. Your voice matters in the hospital. Use it calmly and confidently. Thank you for listening. If today's episode helped clarify a medical or legal issue, or made you think differently about how emergencies and accountability intersect, that's exactly why this podcast exists. I'm Jess, a family nurse practitioner and legal nurse consultant, and I work with attorneys, organizations, and professionals who need clear medical insight in complex cases. You can learn more or schedule a consultation at faqbynursejessconsulting.com. If you found this episode valuable, please share it, subscribe, and leave a review. It helps this education reach the people who need it most. Until next time, stay informed, stay compassionate, and always put safety first.